Well, thanks very much, Matt, for the opportunity to talk. So, I mean, I hope I can shed a little bit of light on this, but more than anything else, perhaps I can share with you some of the challenges that we have in the neurology clinic in terms of assessing people who present with cognitive problems after head injuries, such as sporting injuries, and how we try to navigate some of those uncertainties. And then last, in a plug for some of the research that we're doing, I think some of the ways that we can hopefully resolve those uncertainties. So now, if the slide presenter works, then I don't have to do a Chris Whitty impression. Then I should be able to advance us one. Let's see if that'll go. There we are, marvelous. So first of all, perhaps some definitions might be helpful here. And I think one of the challenges is when we talk about kind of head injuries and dementia, or traumatic brain injury and dementia, these terms mean very different things to different people. So I'd like to sort of suggest or share a neurological interpretation of the word dementia. So this refers to a clinical syndrome. So it doesn't necessarily tell you what's happening within the brain in terms of pathology, and we use it to refer to a progressive problem, something that worsens over time and involves multiple functions of the brain. And there are lots of confusing schemes to kind of define dementia, but some sort of proposed, I think, relatively sensible schemes involve kind of talking specifically about, as you can see from this figure, what the patient's problems actually are. Their sort of their specific cognitive deficits, the pattern of problems, talking about what you think the underlying pathologies are. And there are a number of sort of biomarkers, blood tests, brain scans and things that can help with that. Talking about the effect it has on the person, so in terms of their functional disability, what they can do for themselves and what they need help with. And integrating those together as one diagnosis. So it's important to make the distinction. So, for example, you might have dementia, and that could be due to Lewy body disease, or an alpha synucleinopathy, for example, or due to Alzheimer's disease. And you can have Alzheimer's disease in the very early stage without dementia. So I think it's important to be clear, particularly when we get into the areas of greater uncertainty with traumatic brain injury. So next up, perhaps I can ask someone to advance the slide. Hopefully that will progress. There we go. So next up, some of the epidemiology with this in mind. So we can see here a number of figures from a large study of several million people in Sweden looking at the long-term risk of dementia after head injury. And this shows a number of important things. First of all, it shows that there's a sort of dose-response relationship between the severity of injury that people have and their likelihood of having dementia. So the risk is higher after moderate to severe injuries and increased, but not as much after a mild injury. And if you have multiple injuries, then the risk is also increased. But it shows a quirk of the epidemiology and precisely this issue about how we label dementia, which is that there's a great peak of dementia diagnoses early after injury. And the likelihood is that these are people who have a new injury-related cognitive problem, which is not progressive and in fact is likely to recover to some extent over time, who are being perhaps mislabeled as having dementia, but referred to as a deficit which is like to be fixed or improve over time, which is kind of critically different from something like Alzheimer's disease, which you would expect to worsen. And so this is dementia risk after kind of injuries which are sort of noticeable in terms of being moderate severe, having some of the scan changes that David Sharp was taking you through. But there is also a risk which is increased after what's likely to be kind of repetitive head impacts. And you may have heard a lot about those in some of the press coverage of things. And we can see some of the epidemiology showing an increased risk of dementia and neurodegenerative disease after association football exposures and rugby exposures, for example. But a lot of the kind of the seminal work in this area is being done in the context of American football in the States, where there's a large brain bank with sort of 1,400 specimens in it, which has informed a lot of the thinking in this area. So we'll hopefully show a figure of CTE. So this is one of the pathologies which can be found in the brain and can be associated with a dementia syndrome. So just like Lewy bodies and alpha synucleinopathy can be seen in the brain in dementia with Lewy bodies, which is often associated with Parkinsonism. People who have had an exposure to head impacts can in some circumstances be found to have this very particular abnormal deposition of the protein called tau that David Sharp was talking about earlier on. And this is seen in a characteristic distribution around the blood vessels at the base of the folds in the brain, the sulci. And this is thought to kind of reflect the distribution of the forces in these locations. And the more extensive the tau deposition, which typically found in older people, the more likely there is to be a clinical syndrome of dementia. And this is particularly associated with kind of repetitive mild injuries rather than moderate severe injuries, which often have a slightly different pathological basis. So, I mean, predicting who's going to have this problem is a really important challenge, and one that we're not very good at yet. So we don't really know who's most at risk and why some people have this problem and others don't. And we don't have any tests to diagnose specifically CTE or chronic traumatic encephalopathy in life. But what we do have is some increasingly precise sort of epidemiology about the degree to which the exposure can predict this. So interestingly, the most important predictor doesn't seem to be how many symptomatic head injuries you have, how many concussions. That doesn't do very well in these big brain bank studies with hundreds of former sportsmen and women. What seems to predict better is just how many years people have participated. So years of play seems to be the best predictor. And there's some interesting work which has been done kind of recently, which suggests that if you take an estimate of someone's kind of cumulative head impact exposure over their career, so you can ask somebody what their different kind of roles were. So this has been done in the American football context, where there are plentiful brain donations, unfortunately, to do the epidemiology. You can estimate using kind of mouthguard accelerometer data people's cumulative exposure dose, and that gives you an even more kind of precise prediction of people's likelihood of having CTE pathologies in the brain. So that's suggesting that I think we will get closer to understanding the risk of this, but we need to probably measure more than just concussions or just symptomatic hits. But things are kind of complex, unfortunately, in that often people with CTE pathology in the brain have other pathologies. So Alzheimer's pathologies, we talked about Lewy bodies, we talked about cerebral amyloid angiopathy, kind of vascular amyloid in the walls of the vessels. And so and TDP43, another protein, a bit like amyloid and tau, can clump up in the brain. And these work together to cause problems. And in fact, some of the recent work suggests that it's the Alzheimer's pathologies which in people with CTE explain most of the dementia problems. So there may be an interaction between CTE pathology and other pathologies to produce the clinical syndrome, but it's certainly not the whole story. And it may well not be most of the story. But I think this needs to be determined. And we've only got very limited data from brain bank studies at the moment. And I think what's needed are tools to diagnose this in life. And then we can do the studies, but we're very much limited by the data we currently have available, which makes it pretty hard to counsel people. So this complicated sentence, my translation at the bottom here says not everybody gets CTE, and it's not clear who's susceptible or why. So there are lots of people who have these exposures, but as far as we know, this is not a ubiquitous finding in healthy control brain banks. So we need to get to the bottom of it, and there's a risk, I think, of bias. That people who have problems or have very substantial exposures are most likely to come to brain banks, and that might distort our understanding of the kind of prevalence of the condition. But that's vital kind of work to be done. So I said I'd talk about the clinical syndrome, and I'll have a go at doing that. But it's not a new observation that people with kind of exposure to repetitive head impacts can have a kind of cognitive syndrome and some behavioural abnormalities. So this is Harrison Martland in the 1920s and 30s, who had this kind of seminal paper called Punch Drunk, describing a number of boxers who had very odd behaviour and a range of cognitive problems. And you can just about see in the background that there's a sort of physics equation up there, something about mass times velocity squared, and a nice diagram with this idea that the forces, the biomechanics on the brain would be relevant to this. So these are not new ideas, but they have evolved over time, and people have made progressive efforts to describe the clinical syndrome. So just as Alzheimer's dementia refers to the typical presentation that people have when they have Alzheimer's disease, we here talk about traumatic encephalopathy syndrome, TES, which is the kind of clinical syndromic counterpart that's thought to go along with CTE. And this is a consensus document from NINDS in the States. And it takes you through a flowchart of different symptoms that you might look for in these sorts of people. It's a research document, a research diagnostic criteria. It's not designed yet or validated for clinical use, but it gives you some idea of what people are thinking might go along with these pathologies of CTE. But the most important part in the equation is the exposure. And we've talked about exposure duration being important. And so at the start of these, they set out some proposals, which is sort of at a minimum thinks about people having kind of 5 years of a sort of serious repetitive impact exposure, such as American football participation. And they talk about other groups being at risk and comment on military service personnel, people who have repetitive low-level blast exposure, people like breachers. So there's a range of people who have a relevant exposure. But it seems that having a more significant exposure, a longer duration or a more severe impact, is a reasonable predictor of what happens next, and probably a better predictor than a lot of the symptoms which are shown in this figure here. One of the important things here is, so we'll go through it in turn, but they talk about having cognitive problems, so particularly sort of memory issues are seen, and behavioural problems are also seen, so anger, irritability, kind of explosive outbursts. And not fully accounted for or explained by something else. So if someone has a pre-existing, a clear neurological diagnosis that explains everything, then this wouldn't be the right diagnosis. And this is in the absence, I should say, of ongoing exposure to head impacts or head injury. So that would obviously complicate matters if somebody had a recent injury and you're trying to assess them for a progressive problem, because you might see them at some point on the kind of recovery trajectory of that injury. Does this work? Well, it's not totally clear whether it works or not, but I mean, I would say as a note of caution that this kind of algorithm, this diagnostic tool, is a bit like any kind of computer algorithm, and in some ways it's a product of its training, and it works in a sort of black box way, and so it's only as good as the data that you use to kind of set up the tool. So it's been kind of programmed, I guess. The algorithm has been designed based on brain bank data from predominantly male American football players from brain bank, mostly in Boston at one university. And so how this might apply, for example, to association footballers, rugby players, people of female sex, for example, is less clear. And I think, therefore, there is, a very, very major kind of note of caution about using this, because what you can do is you can take somebody through the whole kind of flow diagram, and it asks about various symptoms, and you can see some kind of comments about those on this screen. But if you follow it blindly, you will end up at a kind of probability in the bottom row that this person has CTE. So you can have suspected CTE or probable. I mean, definite is for when there's kind of pathological confirmation. But if you put in a person for whom this tool is kind of not designed, then you may get an answer out that's kind of completely nonsense and perhaps causes a great deal of concern. And this is some work just kind of highlighting the point that if you forget about the exposure, the head impact exposure, the symptoms that this tool looks for are incredibly common, which is a reflection of the reality in the neurology clinic, that memory problems are not uncommon, and some of the kind of behavioural difficulties again are not common, particularly in people who've had TBI. And so it's a difficult job. These symptoms are non-specific. However, there's been some kind of early work at validating this tool, and it does seem that there is a sort of neurodegenerative signal. So with some caveats. So this is work from a fighters study. This is people who were having active, ongoing exposure to head impacts, which is not ideal for reasons we've talked about already. But the TES kind of classification, were able to separate people on the basis of brain shrinkage. So people who had this kind of clinical syndrome seem to have volume reductions in important kind of relevant parts of the brain, such as the hippocampus, which is kind of key for memory. It's an early region that's involved in Alzheimer's disease, thalamus, and some ventricular enlargement, suggesting there's been kind of shrinkage of the brain parenchyma. And there has been, some work that suggests that this is, a biologically kind of definable entity. So this is an elegant study in American footballers who stratified the group by whether they had, so you can see healthy controls on the left in each of these plots, Alzheimer's disease and repetitive head impacts and TES participants here. And they split those by whether they had amyloid beta absent or present. And the important thing here is that this removes the Alzheimer's co-pathology. So you can see here that in people with no amyloid pathology, A beta negative, that there is a distinct elevation in this inflammatory marker in blood, interleukin 6. So it seems to be possible kind of biochemically to tease out this group. In fact, I think the figure wasn't showing. There we go. There's the figure. So you can see in the right of the three figures here, the box plot, the fourth one in from the left, there's a distinct elevation in this marker. So, repetitive injury, inflammation, neurodegeneration. Hopefully you should have another slide. There we go. And so this is what I was referring to, at the bottom of this kind of algorithm, that you can have a kind of rating of the probability of CT that takes into account these kind of core symptoms, as well as the degree of limitation. So having told you lots about that, and I think some of its limitations, this is not something that we use clinically, and it's something that we grade people with in a research context. But I think the people who made the tool would not be using it clinically, and it's not something that I'm particularly comfortable with using yet. So broadly, the approach that I think is useful in people in this circumstance is first of all to very clearly understand the exposure. We're talking about kind of symptomatic injuries, sort of subclinical repetitive impacts, or sort of moderate severe TBI. I think they have different implications for the prognosis. I think it's important to know that people aren't having an ongoing exposure. And then a kind of clinical assessment and history, like in any kind of cognitive disorders clinic. This is always a key thing, which is the kind of collateral history. So taking a history from a caregiver who knows the participant well, and that would give you an idea about progression and the person's insight into their symptoms. I think understanding the functional impact is important if we're going to stratify this about whether this is kind of subjective impairment or kind of a mild cognitive impairment that people are still able to carry on their functions, or something more advanced such as dementia. And I think the language is important in this context, and to assess people over time. And this can be supplemented by biomarkers. We do have already useful tools. So this is an example of a neuropsychology test. This is a Stroop test. So you can sensitively measure people's performance on memory testing and track that over time, which is important. Standard kind of cognitive screening bloods, things like B12s, and understanding people's vascular risk, substances, alcohol, and so forth. Again, it's basic stuff, but important. And then a range of imaging tools. So, understanding the pattern of brain shrinkage is helpful. So we know what Alzheimer's disease looks like. We're less certain how CTE looks, but we think that frontal atrophy is probably a relatively distinctive part of the syndrome. In a proportion of cases, we can see abnormalities of the ventricular septum. so-called cavum septum pellucidum, although that's often found in people without CTE or repetitive head impacts, and sometimes microbleeds, although again, that's probably not super specific of this condition, is seen in more severe injuries. And so David Sharp's been through lots of this already, but it can be useful to look for conditions that we know about. So amyloid PET or cerebrospinal fluid tests for amyloid markers can be highly informative in this circumstance, and in the coming era of disease-modifying treatments, are likely to have kind of treatment implications. And then there are some PET studies which may be useful in showing, for example, reduced glucose metabolism frontally in this condition. But this is very much a work in progress. And there's some suggestion that tau PET could tell you something, given that tau is the main pathology in these patients. But as you can see from the table on the right, it doesn't map perfectly to whether people had traumatic encephalopathy syndrome or indeed CTE confirmed post-mortem. So there's lots to be done in developing specific markers. We've heard about a range of fluid biomarkers for injury, and in the degenerative kind of late chronic phase. And the work is to try and find specific markers for this condition, because the pathology is specific, but we don't yet have these. And that's what a lot of the important ongoing research is doing. And it's likely, given the range of co-pathologies and things, that we're going to need to combine a number of markers, just like in Alzheimer's, we combine amyloid, tau, and degeneration markers. I think in post-traumatic dementia, which may or may not include CT, we need to include a range of markers. And this talk's not focused on management, but it matters. All of this matters because there's much you can do for all the different problems. And along the similar lines to what Richard Sylvester talked about earlier on, there are a range of treatments which can and should be given symptomatically. And I think unless we get better at diagnosing the problems and identifying things and developing specific tests, we're not going to get to kind of disease modification. So there's a great rationale for doing some of the ongoing kind of longitudinal assessment. And the Advanced Brain Health Clinic based at ISEH, which Matt's sort of talked about already, is one example of somewhere that we're doing very, very detailed testing of people with a significant head impact exposure and better understanding, I think, what the brain health consequences are and how these evolve over time using advanced fluid biomarkers and brain imaging. So I better wrap up at that point, and thank you very much for your attention and the whole team who've contributed to some of this work as well.